guys, it's Kiana back with Browns All Around, and today I am Nurse ICURNVUS. So I got a little flack from not first telling you guys what ICURNVUS means, so I've got to give you the skinny on that. ICURNVUS is it is my name on YouTube for this part of the channel, but when I first got into cardiovascular intensive care, I heard the stories that ICURNs or ICU nurses were like the creme de la creme, the cream of the crop. They know everything. They think they know everything. They're alpha personalities, and some of that's true. Like, we are alpha personalities, and our assessment skills are really like spot on most of the time. We have a lot of autonomy in ICU. So that's where ICURNVUS came from. It's ICU, because I'm an ICU nurse, RN for registered nurse, envious. So basically people are envious of ICU nurses. And not really. It's just a play on words. It's a little, what do you call those things? Oh gosh, I can't even remember. Like, but you know, whatever. It's just a name. That's all. It's all a name. It's nothing anybody's got to go crazy about. But that's what ICURNVUS comes from, and that is my name on this channel, or this part of the channel where I talk all things nursing. So anyway, it's story time. I've got a story. So the other night, I was working in a rural health facility. It is an acute care facility, but it's a rural health facility. It is in a very small area. It is a sister hospital to a very large hospital in the next city over, where I actually live, in that other city. And I used to work at the large sister facility. Well, I was working the ICU there and walk in and realize that I have 3 patients. And you don't even have 3 patients in ICU, first of all. Like, every now and again, maybe. But typically you have 2. And where I came from, CVICU, you would have 1 sometimes, even depending if they were like CRRT or they were post-op cabbage. You would at least have them by yourself for a couple of hours until they were so many hours post-op. So I am used to having no more than 2 patients in ICU. So when I walk in and there's only 2 nurses and there's 6 patients, and I've got 1 going out and I've got 1 that just came in, and the other nurse is getting an admission, and 1 patient's being transferred to the larger sister hospital, and I'm like, okay, I'm mad already because they asked me to come in and I didn't want to go in, but I'm doing it for the team, you know, I'll put myself in people's shoes. So anyway, they give me this 1 patient who has been there for quite some time. I think he had think about it. His family was kind of, for lack of better words, bothersome, you know. And I usually do really well with those kinds of patients. So I was ready, you know, just to go ahead and get that night over with. So anyway, my 3 patients were as follows. I've got this 1 patient who is an elderly gentleman. He's 96 years old, and he came in with shortness of breath that he had been experienced for several days. His daughter went to his house because he said the shortness of breath had gotten worse. He gets admitted to the hospital, and his admitting diagnosis is sepsis. Dun, dun, dun. Okay, so that's my first patient. Pretty much stable when I get there, when I get report. Next patient, 42-year-old gentleman who had a tonsillar abscess and had the abscess drained earlier that day. He was intubated. When they extubated him, he had a bronchospasm, so they basically put him in the ICU to monitor him overnight. Very stable patient, not many issues, but those are the ones that you have to watch. So then I had this 3rd patient who was a patient who originally came in with DTs, or delirium tremens, where the patient is basically having withdrawals from alcohol abuse. He ended up being sent to the sister facility where he had a stroke, ended up being trached, and because he did not have insurance, they sent the patient back to the smaller facility in the ICU, basically because he didn't have anywhere else to go. So those are my patients. So true to form, the patient had several family members of the female gender, and he was the only brother, and they were very, very hoverish. That's the kind of family they were. They wanted to tell you what to do. They wanted to tell you how to do it, but they didn't want to do it, And so I was like, well, what about, teaching them how to do things so when they take him home? And of course, their words were, we ain't taking him home. Y'all gonna take care of him. So that was that. Then, so that I was just aggravated. So, but I'm doing my thing. I'm taking care of him, being the sweet nurse that I am. And the patients that you normally think that you don't have to watch as close are usually the patients that you need to watch the closest. And this is what I mean by that, because I said in a previous video that my assessment skills were one of the things that I felt like was my greatest attributes, or one of the greatest skills that I had as a registered nurse. So I've got this patient that's really young, 42 years old, had the peritonsillar abscess. The abscess has been, taken care of. He's post-op. He'll probably go to the floor the next day, get some antibiotics, and then he'll go home. He had this nagging cough that was kind of bothering me a little bit. I'm not going to lie. It was kind of bothering me. I know he had a bronchospasm. I know that, he had been extubated. I know that your throat can be irritated after you've been extubated. So kind of just wanted to keep an eye on him. His vital signs were pretty much stable. Sometimes they would dip down low. Sometimes they would be up high. But I was like, that's positional. Then I had this elderly gentleman who, for all intents and purposes, was pretty stable. His vital signs were stable. And then I had this impulsive stroke patient that was trach that was not at all oriented to anything. So of those patients, who do you think was the patient that was the most critical, or who ended up being my most critical patient that night? Well, it wasn't the 42-year-old, because I actually had to go and do a little bit further assessment with him, because the cough was really bothering me, and it was a productive cough. So I asked him, I said, is that, are you okay? Are you irritated? Are you having any trouble breathing? Well, he wasn't having any trouble breathing. And he told me, because I further assessed the situation, he said, well, I'm a heavy smoker, and I had this cough before I even came in to have this surgery done. He actually had another tonsillar abscess some months back and had this same surgery not long ago. So, okay, check. He's good. Continue monitoring him throughout the night. Well, the other man basically is there to be monitored too, because he doesn't have anywhere to go. The gentleman that's trached, and he's very impulsive, and I got some orders on him throughout the night to kind of keep him settled down. His family was at his bedside every second of the night, and I think they thought I was going to do the same thing, but the fact of the matter is I just didn't have the time. I couldn't stay there. I couldn't stay there and keep him from hitting his head on the side of the bed, because he was thrashing about, and I already knew restraints were out of the question for this family. They weren't going to have it. They didn't even want us to give him anything sedative, but then they didn't want him all over the place, and then they wanted you to stand at the bedside and keep him from hitting his head so that they could take a nap. That ain't going to happen. So anyway, the 96-year-old patient, who was stable when I got there, I started to notice that his blood pressure was dropping. Well, with sepsis patients, sometimes you do have an unusually low blood pressure. Sometimes you do have an extremely high temperature. Sometimes you have a low temperature. Sometimes you'll have an elevated heart rate. So he was starting to be a little concerning to me. And because they're on hemodynamics, I just decided, okay, I'm going to really watch him. Pressure got systolically in the 80s. Pressure got systolically in the 70s. So we went in, checked on him. He was asymptomatic. He was sleeping really hard, but his daughter, who was at his bedside, said, well, he hasn't slept in a couple of days since he got here, so maybe he's just really tired. Okay, and he is old, but other than, his age, he actually was a very healthy 96-year-old gentleman. Didn't look a day over 75, to be honest with you. So I said, well, I'm going to let his blood pressure recycle in a little while, naturally in an hour, because I am monitoring him very closely, and see if his blood pressure stays low and make sure it's not positional. So we changed his position in the bed. We changed the position of the cuff on his arm. So when the pressure recycles, he's still systolically in the 80s, and that's just not normal. And his MAP was 45. So I said, okay, we've got a mid-level provider here. We have nurse practitioners. I'm going to call him and just see what he wants to do. So when he asked me about his pressures, I told him how he had been trending. I told him that his MAP was 45, and he said, oh, that's too low. So we're going to have to start him on what? You guessed it, ICURNVUS, Levophed, or our trusty friend norepinephrine. So I ended up starting this gentleman on norepinephrine. And let me tell you something about this rural facility, okay? So the first time I heard somebody say this, I was like, you say what? Because there's no pharmacist on at night, you have to mix some of your own drugs. So I was like, what? Okay. So the first time I had to mix something, I was super like nervous, but it was an antibiotic, and it wasn't really that difficult. And I did it, and I felt like I had done something. There's this little clean mixing area where you actually, take the drugs and you do the mixing or whatever. And I'm like, oh, this is what they do. Okay, this isn't bad. Instead of getting a pre-mixed dose of like Zosyn or something, you just have to mix it yourself. And it's not like the mini bag where you do the little connector thing. It's like you actually have to dilute the drug with the powdered form with the dilutant, like a normal saline or a sterile water, and then you take that and you inject it into the normal saline bag. So I was like, what? But see, now this is different. This was Levophed. So I was like, oh, wait a minute. Now I'm a little bit nervous here. And the order was like 16 mics and 250 cc's of normal saline. And I'm like, oh no, like I'm not ready to do this. Like that, I don't know why, but it just made me so nervous. So anyway, they brought it to me already mixed. The nursing supervisor mixed it. But isn't that something? Like I was like, oh, I'm mixing drugs up in here. But anyway. So my patient goes on Levophed. The order said that we could start it off at 0.5 mics a minute. There was no titration like parameters, so I was just going to gauge the blood pressure. So I started him at 0.5, and he hadn't had a bolus yet. So I talked back to the nurse practitioner, and he said, well, he is a heart failure patient, so he didn't want to pump him with too much, but he put in an order for a 250 cc bolus of normal saline. I said, okay, so and he had 2 IVs. So, because see, the thing that you would have worried about, if you got the Levophed going and then you've got this bolus, so he had 2 separate IV sites. So, and he actually had a PICC line, but I still worry about that stuff because I don't want that one drug to go running in at that, really fast rate when you're bolusing a patient. For those who don't know, I know other nurses, if you're watching it, but he had a separate IV site. He had a number 20 in his wrist. So, hooked the bolus up, ran it 999, clear, and then started the Levophed, watched his blood pressure recycle. The first one was like systolically in the 90s, but his MAP was still 55. And you want the MAP to be at least 60 for patients because his EF wasn't really that bad. His ejection fraction wasn't that bad. So I give him the bolus. His blood pressure is still systolically in the 80s. His MAP was still like in the 50s. And that's just not what I wanted. I wanted him to be a little bit higher systolically, which is the top blood pressure number. And then I wanted his MAP to get up above 60. And I think at that time, like the next blood pressure that cycled, it was like 55. So I was feeling a little bit better. And the Levophed was still at 0.5. So I took it up a notch to 1. So he was getting 1 mic per minute. He had the bolus. Blood pressure recycled. And his pressure was systolically in the 90s again. His MAP was like 57, 58. But I'm still looking for the 60. So I had his blood pressure, his hemodynamics going where I increased the blood pressure intervals because it was at 1 hour. Because in that unit, we have to do blood pressures at least every hour. And then if the patient is, of course, more critical, then I reset the hemodynamics to recycle every 15 minutes. So the next blood pressure that came up, he was systolically still in the 90s, but his MAP was over 60. So that made me feel a little bit better. But I wasn't ready to turn the Levophed down. I wanted to make sure. So I waited for the next blood pressure to recycle. And when the blood pressure recycled, he was still good in his MAP. It was over 60. Systolically, he was in the low 100s. His diastolic blood pressure was still low, but like I said, he's a heart failure patient. Or he has a history of heart failure. So that was just that. Without really good assessment skills, that could have went left really quickly. Without good assessment skills, that 42-year-old gentleman could have went left really quickly. So more of the story is to just trust your instincts and do what's best for the patient. But that was just something that happened in the ICU, and I felt really good about it, actually. So anyways, be sure to like, comment, and subscribe to Browns All Around so you can see what the ICURNVUS nurse is up to next. Thanks, guys. Bye.